Aloha and welcome to our lecture today. We are going to continue talking about disorders that cause some discomfort in our joints. And so let's go ahead and jump right in. We're going to talk about arthritis, and there are different types of arthritis that we're going to be looking at in more detail today. So as a general definition, arthritis is inflammation of a joint. And the three types that we're going to look at are osteoarthritis, rheumatoid arthritis, and gout or gouty arthritis. And osteoarthritis is also called degenerative joint disease. So you might look at a patient's chart and you might see DJD, and that's really just a little acronym for degenerative joint disease. So keep your eye out for this in the chart. It might just be referred to as osteoarthritis. But osteoarthritis, or DJD, has a very insidious onset. And what we mean by that is that it comes on and it gets worse over time. It's the most common form of arthritis, and there's really kind of two different types. There's idiopathic arthritis, that's osteoarthritis, and idiopathic means we're not really sure what causes it. And then there's secondary osteoarthritis. And in secondary causes, we know that age and genetics can play a role, meaning that older people tend to get osteoarthritis more frequently than younger people. And also that families tend to have osteoarthritis run in their families. So that's kind of a form of genetics. A secondary cause also can be contributed to obesity. And this would be, in particular, osteoarthritis of the knees, the knee joints. And this is due to the extra weight of the upper body putting extra stress on the joints of the knee, the hinge joints in the knees. And so this is a secondary cause of osteoarthritis. Other causes which are secondary could be from overuse. Athletes tend to get osteoarthritis, so sports, football, soccer, basketball. And then also occupations. So certain occupations like carpentry, painters, things that require frequent kneeling and stooping can cause a secondary osteoarthritis as well. Menopause is another cause, and this is due to decreased levels of estrogen. So after menopause, estrogen levels go down, and this increases a woman's risk of getting osteoarthritis. So what is the pathophysiology? In osteoarthritis, we learned before when we studied about joints that cartilage is a natural shock absorber, and it cushions the ends of the bones and reduces friction in healthy joints. Here's an example of an arthritic hip joint, and we can see here that the bone is rough. We've got cartilage that's been worn down, and what we've got here is bone rubbing against bone. Over on the other side, we can see that normal hip joint with that nice, smooth, articular surface there. We've got good cartilage in place, but then in the other picture, we can clearly see that we've got worn down cartilage and roughened bone. And so what happens is this cartilage becomes more vulnerable to wear and tear. It becomes softer and less elastic. And then repetitive use of this joint over time wears down the cartilage. And the new cartilage being formed cannot be produced fast enough to balance out the loss. And so the deterioration of this cartilage causes the bone to rub against bone, causing pain and reducing range of motion. So we can have a decreased range of motion and definite pain. There can be stiffness, especially in the morning. You'll hear some people that have osteoarthritis actually talk about the fact that they need to get up and they need to get moving, because actually getting up and moving around helps them actually feel a little bit better. Because when they first get up in the morning, they feel really stiff. Crepitus is when the loose cartilage causes like a grating sensation or a popping, crackling sound that can be felt. So you can put your hand over the joint and have the individual flex and extend, and you can kind of feel that sensation of that popping or crackling. And then, of course, deformity. And we're going to take a look at some pictures of some deformity that occurs in osteoarthritis here in a little bit. So here we're looking at crepitus. We can see here we've got osteoarthritis and hypertrophy and spurring of bone and erosion of cartilage. So spurs on bones are just like these little kind of bumpy edges that are on the bone as the bone rubs against its other bone that it articulates with. And so again, we can see both an image of a healthy knee joint and then an arthritic knee joint. Heberden and Bouchard's nodes are also something that happens in osteoarthritis, and you can see in these joints of the finger where there is some bone spurring, there's some swelling that takes place, and you can actually look at a person's hand and see that these nodes are areas where the finger is thickened, it's enlarged, it looks swollen, right where that joint is. And so what do we want to do about it? How do we treat osteoarthritis? We want to balance rest and activity. So joint immobilization should not be prolonged due to the fact that people really get kind of stiff if they don't move around. We want to encourage them to have a balance between their rest and their activity, not to overdo it, but not to be too sedentary either. We can also have the addition of a ADL assistance with activities of daily living and ambulation. We can have them use a cane, a walker, maybe crutches for a period of time. But we do want them to get up and move around if they can. So heat therapy is really helpful when stiffness is a concern. And then cold therapy can be used to reduce the inflammation and the swelling. And it's really important to use these non-pharmacologic options for pain relief in osteoarthritis. They can actually be very helpful if the patient can have a nice routine where they're using heat and cold therapy as needed. Of course, if the issue at hand is that the individual is overweight, it's possible that weight reduction can help. Diet and exercise, of course, can help. And low impact exercises like swimming, walking, or bicycling, yoga, and massage also can be very therapeutic in the case of osteoarthritis treatment. I want to stress swimming in particular because the nice thing about swimming is that you're not really putting a lot of pressure on the joints, right? If you're swimming, you're getting good movement, right? Good range of motion, and you're not putting a lot of impact on the joint, which, any impact is going to cause that irritation and swelling to be worse. So we want to encourage swimming and yoga especially. Training with light weights can actually be helpful by strengthening the muscles that surround the joint. So we want to encourage light weights as well. And then, of course, there are drug treatments to help with the pain and the inflammation. So over-the-counter anti-inflammatory medications such as aspirin, ibuprofen, or acetaminophen. Also glucosamine is another kind of a supplement that we encourage folks to take that kind of helps with kind of rebuilding the joint. There are also some pain relieving creams like Aspercreme, which contains basically salicylic acid. It can help with the pain relief and decrease some of that inflammation. So these are all kind of options that the physician may present to the patient. Glucosamine I mentioned before, which is chondroitin sulfate. This can be purchased at the health food store. It's essential for the formation of cartilage and synovial fluid. And some people find that this is really helpful for them. Other people maybe don't get a major effect from glucosamine, but the people who do really say that it is a great choice for helping with their osteoarthritis. So different things work for different people. We can also do steroids if necessary. We can do an intra-articular injection directly into the joint space. We can also do steroids by mouth or intramuscularly. And we know that steroids decrease inflammation, and so that's how they're helpful in the treatment of osteoarthritis. And surgery. So when pain and immobility really make normal functioning impossible, many people become candidates for artificial or prosthetic joint implants using a procedure called arthroplasty. And so in the next slide here, I have two images for you to see here. This is a total knee replacement, and there's a couple different ways that you might see this in the chart. You might see it abbreviated as TKR, total knee arthroplasty, TKA. These are all the same thing. And what happens is they go in and they shave the head of the tibia, because what they want to do is get rid of that jaggedy bone where those bone spurs are. And then what they do is they put a prosthetic in place, which is an artificial joint. And then the patient has to do some rehabilitation to get that joint strengthened. And you might see a patient come back from a total knee replacement with a continuous passive motion machine, oftentimes just referred to as the CPM machine. And so this is what it looks like. And so the patient will be laying in the bed, and they'll have their leg in this machine that is exercising their leg. It's a CPM. This is another view of what the machine looks like. So it's a device that's used to gently flex and extend the knee joint passively as the patient rests in bed. And the CPM machine is used to allow the knee joint to very slowly move. It improves motion following the knee replacement, and it can help eliminate some stiffness. And by placing the joint in a CPM soon after, hopefully we can reduce the amount of scar tissue. So evidence shows that scar tissue is going to be less likely to develop if we can gently flex and extend that knee very soon after surgery. I put this image in here because I want you to think to yourself, what is wrong with this picture? Give you a second to think about it. The thing that's wrong with this picture is that we need to put up the bed rails, right? So we have this individual's leg in a CPM machine, We do not want that CPM machine to somehow get knocked off the bed with this individual's leg in it. So it's very important when you have patients on CPM machines that we keep the side rails up because that is definitely a safety issue. There is a small like handheld device that will actually use to control the degree of flexion and extension. And these are usually put on by physical therapy, and they're usually monitored by the physical therapist in terms of how much we're going to increase the angle of extension and flexion. But that is usually something that is handled between the physician, the surgeon, and the physical therapist, although nurses oftentimes will maybe stop the CPM machine to help the patient get up for whatever reason, and then sometimes we will put them back on the CPM machine. So it's really good to know a little bit about it if you're going to be taking care of patients that are using this. Okay. So let's take a little bit of time here to talk about another type of arthritis. This is rheumatoid arthritis, which is different than osteoarthritis. Rheumatoid arthritis is a systemic inflammatory disease. Okay? Now the joints of the body are usually the most affected. All right? However, the inflammation in rheumatoid arthritis can actually affect organs and other areas of the body too. So here we can see some of the different joints that can be affected in the body by rheumatoid arthritis, and there's usually not only a systemic type of inflammation, but it's usually on both sides equally. So this is something that's a little bit different. In osteoarthritis, you might just have one knee that is arthritic. In rheumatoid arthritis, it's usually bilaterally. And so it may initially begin in a couple of joints only, and most frequently attacks occur in the wrists, the hands, the elbows, the shoulders, the knees, and the ankles. Rheumatoid arthritis is a disease that kind of waxes and wanes, and that means it comes and it goes. So remember when we were talking about osteoarthritis, we said that it had a slow, insidious onset, and over time, it tends to get worse and worse and worse. Rheumatoid arthritis is a little different in that it waxes and wanes, and you can have something called an exacerbation. I think I've used this word in other lectures. An exacerbation is when you kind of have a chronic disease, and then you go through a period where you're having an exacerbation of it. So in other words, in arthritis, your joints become red, swollen, painful, and tender. So you have an episode where your rheumatoid arthritis is flaring up. In rheumatoid arthritis, the synovial membrane can become inflamed, and this can result actually in the production of excessive synovial fluid. And so synovitis is when this synovium becomes thickened and inflamed. And so we can kind of look at a couple of different images here. We can see a normal joint, and then we can see osteoarthritis where we've got these bone ends rubbing together. And then we've got rheumatoid arthritis here where we can see that the capsule, right, around the joint is swollen and inflamed, that synovial membrane, and then there's also erosion of the bone as well. We can also have inflammation of the glands, of the eyes and mouth. This can cause dryness in these areas as well. So like we mentioned before, in rheumatoid arthritis, there can be organ involvement. Inflammation of the lining of the lung, pleuritis, which can cause chest pain with deep breathing and coughing is another example. And then tissue inflammation surrounding the heart. is called pericarditis, and this can happen as well. It can also reduce the number of red blood cells and white blood cells. And so how do we find out whether or not an individual has rheumatoid arthritis or maybe osteoarthritis? Well, there's different ways that we can do some diagnostic testing, but one of the things that we can do is lab work. And so we can check a patient for rheumatoid factor. This is a protein that's produced by the immune system, and it's sometimes found in patients that have rheumatoid arthritis. C-reactive protein is another blood test that we can use to detect inflammation within the body. Another lab we can do is called an erythrocyte sedimentation rate, or a SED rate. You'll hear it referred to as a SED rate. And so here we have a tube of blood, and over time what will happen is the cells of the blood will settle and they'll separate from the serum. Okay, so you can watch that happening in this animation here. And so what happens is any inflammatory process results in high fibrinogen in the blood, and this causes the red blood cells to stick to each other. And when this happens, the faster they settle, the higher the SED rate. So a normal SED rate is about 3 to 20 millimeters per hour. It's a little faster in women than men, and also in older folks than it is in younger. So these are some labs that you might see ordered. We can also do an arthrocentesis, and this is where there is a needle used to drain some of the synovial fluid. It can be helpful in relieving the pain of the joint effusion if there is excess synovial fluid, but we can also analyze that joint fluid to see if there could be other causes like gout, which we're going to talk about here in a minute, or an infection in that joint. So treatments for rheumatoid arthritis would be non-steroidal anti-inflammatories like ibuprofen and corticosteroids, as well as methotrexate and some other drugs that you see listed here. Also, estrogen replacement therapy may be used as a preventative therapy after menopause, along with calcium supplementation to just kind of as a preventative measure. Calcitonin is secreted by the thyroid gland. It inhibits the osteoclasts. Remember, those break down the bone. We can give that IM, sub-Q, or intranasally. And then we have our Fosamax as well. We said that this was inhibiting our osteoclast bone resorption and increasing our total bone mass. These are mentioned also in our osteoporosis lecture. These drugs have to be taken in the AM with a full glass of water on an empty stomach 30 minutes prior to eating. We don't want people to lie down after. And then our Evista, which is our estrogen receptor modulator. All right, so let's go ahead and move on to gout. Gout is yet a third type of arthritis. And again, it's got a very different cause than the other two. This type of gout occurs when needle-shaped uric acid crystals build up in the joints and tissues. So here we can see an example of what these crystals look like. And the presence of these crystals causes an inflammatory response, or gouty arthritis, and it's really, we get current attacks of painful joint inflammation that take place. And so the formation of something called tophi, these are lumps of collected crystals that are under the skin in the joints and the bones. And so I said we would be looking at some of the different types of deformities that we can see sometimes in our patients who have a gouty arthritis. So you can see that the images here are a little different than the ones that we saw in the osteoarthritis portion of this lecture. You see some very large lumpiness, and this is just inflammation here and swelling. And so also in gout, patients are more prone to having kidney stones, and these stones are actually made out of that uric acid. The gouty nephropathy can actually end up with an obstruction, right? And then you can end up with impaired kidney function as well. And so why does this happen? How does this happen? So purines are nucleotide bases that are found in plant and animal cells. So examples of this are the bases that we find in our DNA, right? And so basically all the foods that we eat, plants and animals, right, they are metabolized into uric acid. And so what happens is when there is increased uric acid production, right, or there's failure of the kidneys to filter out the uric acid, we can end up having too much of it in our body. And although purine-rich foods don't alone cause gout, they can actually trigger an exacerbation of the disease. And so let's look at a couple of examples of some of the foods, like purine-rich foods like meat, liver, poultry. These meats here, you can see examples of how much purine are in these. Seafood, you can see again examples of how much purine are in some of these foods. Alcohol is another one that tends to cause, in some people, an exacerbation of their gouty arthritis. And so we want to make sure that we are educating our patients about the different types of food that might trigger an exacerbation of their gout. And people also want to kind of track what triggers them as well. So keeping like a diet, a history of diary of foods that they eat that tend to cause a problem for them is probably a good idea. So serum uric acid levels are a way for us to check the blood to see if the levels are greater than 6 milligrams per deciliter. Then it may be gout that the patient is suffering from. We can also do a 24-hour urine to test for levels of uric acid elimination, see how well the body is eliminating the uric acid. And then, of course, just by symptoms, right? The patient is reporting different symptoms, and we are, kind of figuring out what type of arthritis this is. So colchicine is a drug that we use for gouty arthritis. It prevents the activation and migration of the neutrophils. So it's kind of thought to mediate some of the gout symptoms, helps decrease the uric acid crystal formation. And a combination drug of this colchicine and probenecid is another one. And the probenecid helps increase the excretion of the uric acid in the urine. You'll also see patients on allopurinol. It helps reduce the production of uric acid by inhibiting the biochemical reactions immediately preceding its formation. Other types of drug therapy will include, again, the nonsteroidal anti-inflammatory drugs like Motrin or Tylenol. And so we want to remember, as we kind of reflect back on this lecture, that there are 3 different types of arthritis: osteoarthritis, rheumatoid arthritis, and gout. They all have quite a different type of cause, and they do tend to have different types of treatments. And so I hope that you can differentiate between the 3 and go back into your clinical and pay attention more closely to the charts to see if you can identify some patients that have these problems, and also identify the different types of therapies that your patients are on to help control the symptoms associated with these types of arthritis. So that is all that I have for you today. I will see you again next time.